The core challenge of clinical psychology is deciding exactly where everyday human struggles end and clinical pathology begins. Normal and abnormal behaviors share the same psychological territory. Their borders shift, blend, and continuously overtake one another. Compounding this difficulty is the way conditions present themselves. The same symptom, such as severe lethargy or disorganized speech, can appear in distinct mental disorders. Without a rigid framework, clinicians struggle to hit a moving target. It is difficult to isolate a specific cluster of behaviors and assign a single, accurate diagnostic label. Because the boundaries of the mind are so fluid, psychology requires structured, objective diagnostic taxonomies. These systems separate overlapping symptoms to determine the proper course of care. The drive to categorize these mental states is often viewed through the lens of modern Western psychiatry, but that framework is one part of a much older story. Humanity has worked to identify and structure the dimensions of the mind for thousands of years, seeking reliable ways to prescribe accurate treatments. The physical reality of human suffering has historically demanded systems capable of separating baseline distress from severe, treatable pathologies. We see this necessity reflected in clinical environments across history. Tracing the architecture of these classifications reveals a long continuum of medical thought, stretching from the ancient biological mappings of Indian Ayurveda to the multi-layered matrix of the modern DSM-4. Though separated by millennia, these diagnostic frameworks share a single objective: isolating acute psychological symptoms from standard behavioral baselines. Thousands of years before modern psychiatry, ancient Indian texts like the Atharvaveda detailed the causes and treatments of abnormal behavior. Early Ayurvedic practitioners evaluated patients based on their Ayu life type. They observed whether a person's existence was primarily happy, unhappy, of service to their community, or a disservice to society. Building on this, scholars like Maharishi Charak categorized human behavior using the Tridosha system. This model evaluated 3 physical doshas, Vata, Pitta, and Kapha, alongside their corresponding mental tendencies. What makes this historical framework relevant today is how accurately these ancient, biologically based categories map onto modern clinical definitions. As we see in this comparative table, the Ayurvedic observations align with modern diagnostic terminology. For instance, the specific erratic behaviors described under ancient Vata mania correspond to the modern clinical classification of schizophrenia. Similarly, the deep lethargy and withdrawal documented as Kapha symptoms mirror the modern clinical definition of affective disorders, specifically depression. Ayurveda established a vital first principle of taxonomy. Internal biological and temperamental states correspond to distinct, categorizable psychological disorders. As clinical psychology evolved, modern Indian psychologists expanded upon these historical concepts to classify abnormal behavior into distinct, measurable tracks. This structural model branches the human psychological experience into specific categories, charting the path from integrated health to severe psychosis. A critical feature of this hierarchy is its division of psychoses based on their origin. It separates conditions of unknown etiology from those triggered by historical, reactive events. The framework also establishes distinct tracking for symptom intensity. It separates mild disorders, such as intense anger or jealousy, from severe disorders, like full schizophrenic breaks or epileptic seizures. This transitional phase proved that clinical diagnosis relies on separating disorders by severity and origin. The need to map these overlapping contextual layers, severity, biology, and triggers, was codified globally by the American Psychiatric Association with the DSM-4. The DSM-4 moved the field away from linear symptom checking, replacing it with a comprehensive 5-dimensional multi-axial assessment. In this matrix, the top layer is Axis 1. This captures the acute clinical syndromes, like mood, anxiety, or somatoform disorders, that typically drive a patient to seek immediate psychiatric attention. Diagnosing an acute condition is incomplete without identifying the patient's underlying foundation. That is mapped on Axis 2. Axis 2 tracks permanent traits established in childhood or adolescence. This includes structural conditions like antisocial, schizoid, or borderline personality disorders. Axis 2 provides the required baseline. A clinician cannot diagnose the acute flare-ups of Axis 1 without understanding the permanent personality foundation beneath it. Even with clinical and personality profiles mapped, the diagnostic picture is incomplete without accounting for the patient's physical health. Moving down the matrix, we find Axis 3. This layer accounts for general medical conditions that contribute to or mimic psychological disorders. By tracking biological realities like nervous system diseases or endocrine imbalances, clinicians ensure physiological problems are not misidentified as purely psychiatric issues. A complete diagnosis must also account for the external world pressing in on the patient. This brings us to Axis 4, which evaluates psychosocial and environmental problems. This layer tracks external sources of stress, from housing crises to occupational struggles. A recent job loss or entanglement with the legal system can alter how an Axis 1 clinical syndrome presents in the examination room. All these overlapping variables, clinical symptoms, personality, biological health, and environmental stressors, culminate in one final metric. The base of the matrix, Axis 5, uses a 100-point scale to evaluate overall occupational and social adaptation, providing a snapshot of their mental state. The multi-axial system proves that an accurate diagnosis requires isolating acute syndromes against somatic health and external life stressors to understand the whole person. The classification of psychopathology has evolved from the etiological models of antiquity into these highly structured multivariate data matrices. Modern clinical interviews are designed to parse out these overlapping variables in real time, separating physical causes from psychological symptoms. Comparing the Ayurvedic system with the DSM-4 matrix reveals a consistent logic. Ayurveda's physical doshas and unhappy life types map directly to the DSM's medical and psychosocial axes. The ancient method of separating biological triggers from social ones remains the critical standard. Modern psychiatric frameworks translate this holistic approach into a rigorous, actionable data structure. These complex taxonomies provide more than a catalog of medical labels. Deliberately separating these overlapping layers allows clinicians to isolate the root causes of abnormal behavior. Treating an underlying physical condition or an environmental stressor often mitigates what appears to be a severe psychiatric symptom. A correct taxonomy restores order. It takes a chaotic set of mental variables and organizes them into a readable, actionable state. Whether utilizing ancient Ayurvedic wisdom or modern DSM multi-axial scales, the purpose of all psychological classification is the same: to map the mind accurately, cut through the complexity of human behavior, and restore functional adaptation.